And
Welcome,
Dr. G,
everybody. I just wanted to welcome you to tonight's meeting. Dr. Gallagher is from University of Michigan or Michigan Medicine, U of M Health, and he's a neurologist and he will present on MG antibodies with question and answer time to follow. Dr. Gallagher completed his undergraduate degree at the University of Michigan, and then he did all the rest at University of Michigan, and attended medical school there as well, on Wayne State University of Medicine in Detroit, Michigan. He completed his residency in neurology and fellowship in neuromuscular medicine at the University of Michigan, where he later joined the neurology faculty. Dr. Gallagher is interested in clinical care of neuromuscular disease and electrodiagnostic procedures, EMG and IOM. His clinical time is primarily spent in the outpatient neuromuscular clinic, providing longitudinal care for patients with neuromuscular conditions. What days are you in clinic, Dr. Gallagher?
Thank you for that introduction, Susan. I'm in clinic Mondays at Northville. I actually go to a couple different sites, but Mondays at Northville, Tuesdays at Taubman, which is kind of our main site at University of Michigan in Ann Arbor. And then I also do a little bit of a muscular dystrophy clinic, and that's on Thursdays. And then I have a CMT clinic on Fridays. So I'm in clinic most days, but my neuromuscular kind of general is mostly Mondays and Tuesdays.
Fantastic. Well, I am anxious to see this presentation. Thank you so much for joining us this evening. And I look forward to seeing what you have.
Great. Thank you so much. Tonight I'll be talking about myasthenia gravis, specifically the antibodies that are present and the impact on our treatment decisions. Before I get started, I know some of you knew James Tiener, Dr. Tiener, and Dr. Tiener was one of my mentors and a very good colleague here at University of Michigan. And he tragically passed away, very unexpected, about a year ago, a little bit over a year ago. And so I wanted to mention him because he took care of a lot of our myasthenia gravis patients, and he was a very compassionate physician. And I know his patients, I've heard from many of his patients that they loved him. When he passed away, the University of Michigan Medical School did a diversity fund, and they've to date raised over $50,000 in his name to contribute to diversity and recruiting good clinicians at the University of Michigan. So that picture on the right is his wife, Carol, and then several of the medical students that were involved in that diversity fund. So I will also mention I don't have any relevant financial disclosures. And I'm going to mention treatments, but I'm not going to advocate for any specific treatment, especially on an individual level. So I'm going to cover kind of broadly all of the treatments that are out there and the role of those treatments with specific types of myasthenia gravis, but I'm not going to speak specifically about any one individual and what they should or shouldn't receive as part of their treatment. As everybody here knows, myasthenia gravis is a neuromuscular disorder. Most of the time it's autoimmune. There are some congenital forms of myasthenia gravis that I'm not going to talk about tonight. And myasthenia gravis is characterized by muscle weakness. It tends to be fluctuating, and the more that somebody does, the more those muscles fatigue and tire out. It can affect the muscles around the eyes, which we call the ocular muscles. Those control the eyelids as well as the movements of the eyes. The bulbar muscles, those are the muscles that help to control our speech and our swallowing, our tongue and the back of our throat. Our limb muscles, those muscles in the shoulders, the arms, the legs, as well as the respiratory muscles, the muscles that help us with breathing. Myasthenia gravis is one of the best understood autoimmune disorders. We, meaning the medical community, have studied this condition extensively, and we know that these antibodies are pathogenic. They cause the disease. And on animal models, when you take these antibodies out of an affected individual and inject or place it into an antibody, you can induce the disease. And we know that by treating these antibodies, helping to remove them or treating the immune system, symptoms can improve. So it's one of the best known autoimmune diseases out there, and there are many autoimmune diseases. This is a scheme that is just showing what should normally happen when we send our electrical signals from our brain. That's going to travel down through a nerve, and that nerve goes right to a muscle. When that nerve impulse gets there, the muscle releases acetylcholine, and acetylcholine comes across what we call the synaptic cleft. So you have the nerve on one side and the muscle on the other, and it's really very microscopic distance. And that acetylcholine binds or sticks to acetylcholine receptors. And in doing so, that generates a muscle contraction. And so that's how we move, that's how we speak, swallow, we move our eyes, we breathe. This process relies on that happening efficiently. And when it does not happen efficiently, we develop weakness. And that's where the symptoms of myasthenia gravis come from. You can see the acetylcholine receptors here. These are on the muscle membrane. And then the MuSK protein is also on the muscle membrane. MuSK is stabilized by a protein called low density related protein 4, or LRP4. And each of these enzymes is very important for maintaining that connection, that nerve to muscle connection. So you might ask, why do we really care about the antibody type? Many years ago, it was fine to just say somebody has myasthenia gravis, and we know that it's an autoimmune disease, so let's just treat the autoimmune disease with therapies that we know work. But over time, we've come to understand that some of these antibodies have very real differences. Even though the clinical symptoms can be very similar among the types of myasthenia gravis, the treatments and the response to treatment does vary depending on the antibody status. And so now, as well as in the future, as even more therapies are developed, you can really start to tailor a treatment very specific for each type of myasthenia gravis. And so this is really important. A lot of our newer medications are becoming very targeted therapies. And that has both pluses as well as some minuses, because somebody might have myasthenia gravis, say seronegative, which we'll talk about. And if you don't respond to that treatment, there are other options out there for treatment. So first, I'm going to talk about acetylcholine receptor antibodies. This is the most well-known and best understood antibody that's present in myasthenia gravis. Acetylcholine receptor antibodies are present in 85% of people who have generalized myasthenia gravis. That's myasthenia gravis affecting our speech and swallowing, our breathing, as well as the muscles in our arms and legs. Acetylcholine receptor antibodies are present at a smaller frequency in people who have only eye symptoms, generally about 50% at the time of diagnosis. When we measure our antibodies, many labs will quantify a binding antibody, a modulating antibody, and a blocking antibody. In general, almost everybody that has acetylcholine receptor antibodies has binding antibodies. And so most labs now will first run that assay. And if somebody has binding antibodies, they often don't go on to do additional antibodies. However, there are a small number of people who have acetylcholine receptor positive myasthenia gravis who have modulating antibodies. Modulating antibodies are found in about 5% of people who don't have binding antibodies, although some people can have what's called a false positive, where they measure positive for modulating antibodies and may not actually have myasthenia gravis. Blocking antibodies are also described, but that's a real small number of people who don't have binding antibodies. High antibody titers are more specific for the diagnosis of myasthenia gravis. And that's really the amount, how much is there in the bloodstream, versus low titers. Occasionally we can see people who may not have myasthenia gravis, but have a different autoimmune condition that might have a low amount of these acetylcholine receptor antibodies. Most labs will give us a very specific amount, measured anywhere from 0.02 up to into the hundreds potentially. When you look kind of as a whole, the actual amount of antibodies does not always indicate the severity of disease, even though I said higher antibodies in general correlate more with more severe disease. But if you take one person and their antibody levels are high and another person and their antibody levels are low, sometimes that person that has lower antibody levels still can have more severe disease. So when you compare two people together, you can't actually compare their antibody levels and know for sure which person will have more severe symptoms and which person might not have severe symptoms. And certainly people who have low amounts or even antibody negative patients can have very severe clinical disease. So the amounts don't always correlate with how severely affected somebody is. Acetylcholine receptor antibodies. So antibodies actually come in 4 different flavors. There's IgG1, IgG2, IgG3, and IgG4. Acetylcholine receptor antibodies tend to be IgG1 and IgG3. These antibodies activate part of our immune system called complement. So the antibodies themselves are directly pathogenic. They can bind to the acetylcholine receptors, resulting in cross-linking, and then the muscle membrane pulls those inside, so they're inside the muscle, where they can no longer receive that transmission from the nerve. Also, with complement, that part of the immune system ends up causing direct damage to the muscle membrane. Once complement is activated and the muscle membrane is damaged, that takes a lot longer for the muscle membrane to heal. And in some cases, if it goes on for long enough, it can be difficult to fully reverse that damage that occurs. We do think of muscle as being something that can regenerate fairly well, but if it happens for long enough over time, there's the potential that there may not be full regeneration. The end result, either from binding and internalization, functional blocking, where it just can't receive the signal, or the damage with complement and damage to those acetylcholine receptors, is that your muscle membrane can no longer receive the signal, and your clinical symptom is weakness of that particular muscle. With acetylcholine receptor antibodies, it's very important to think about the thymus gland. The thymus gland sits right behind the sternum, and in people who have acetylcholine receptor positive myasthenia gravis, thymic hyperplasia and thymoma are very common. About 3/4 of people that have acetylcholine receptor antibody positive myasthenia have thymus gland abnormalities. Sometimes that's evident on a CAT scan of the chest. Sometimes it's only evident on a microscopic level after the thymus gland has been removed. This is especially important in younger individuals. It's much more common to have a thymoma or thymic abnormalities in patients under the age of 50 than over the age of 60. And there's kind of this bimodal period where younger individuals, there's a little bit of a lull, kind of midlife, and then it rises again over the age of 60. So younger individuals with acetylcholine receptor antibodies are very likely to have thymic abnormalities. I'm going to switch gears and just talk about MuSK protein. MuSK stands for muscle specific kinase, MuSK. And this MuSK protein sits in the muscle membrane right next to the acetylcholine receptors. And it helps to stabilize those acetylcholine receptors. There's other proteins around it that are also very important. There's a protein called rapsin and a protein called DOX7. These proteins are implicated in congenital myasthenia gravis, not yet fully implicated in autoimmune myasthenia gravis. LRP4, which we'll talk about, is another protein that can have antibodies and result in autoimmune myasthenia gravis. And agrin is another protein that's very important. So this whole complex helps to stabilize our acetylcholine receptor antibodies. MuSK myasthenia is a much less common form of myasthenia gravis than acetylcholine receptor positive myasthenia gravis. This is about 5 to 6 to maybe 8% of myasthenia gravis patients, kind of depends on the study. It does tend to, MuSK patients do tend to skew a little bit younger, and it does tend to be more women than men. MuSK myasthenia can be quite severe in some individuals. It often affects the muscles of speech and swallowing, so swallowing difficulty is very common. And I've seen a few patients who have presented with really bad respiratory weakness end up on a ventilator, and they don't have any other obvious manifestations of myasthenia gravis. Their eyes are moving fine, if they weren't on a ventilator, they could speak and they were swallowing fine. But isolated respiratory weakness or severe generalized weakness is a component that we can see. MuSK antibodies actually don't tend to activate complement. So they're the IgG4 subclass instead of the IgG3 or IgG1 like acetylcholine receptor. It used to be thought that people could not have both acetylcholine receptor and MuSK antibodies, but it's become clearer over time with more testing that some people do have both. Most of the time, our testing algorithm will say test for acetylcholine receptor antibodies. If they're present, you may not even go on and do additional testing. So many times in the past, people were only tested for acetylcholine receptor antibodies and they weren't tested for MuSK. So it is a thought that maybe both tests should be run, even if one of them is abnormal. And usually, since acetylcholine receptor antibodies are more common, that's the one that's run first. LRP4 antibodies are also found. This is a real small minority of patients who don't have detectable antibodies to acetylcholine receptor or MuSK. It's about 1 to 2% of myasthenia gravis. That LRP4 protein is important for helping to stabilize MuSK and acetylcholine receptors and really get them to be stable and receive that signal. It's thought that antibodies to LRP4 are pathogenic by affecting MuSK. So sometimes the symptoms can be somewhat similar to MuSK and how they present, sometimes a little bit more severe than acetylcholine receptor positive myasthenia. And then I need to mention that there's also antibody negative myasthenia gravis. Depending on the study, this may be 10 to 15% of individuals who have myasthenia gravis, but don't have identifiable antibodies to acetylcholine receptor, MuSK, or LRP4. With that being said, there's newer, primarily research-based, cellular-based antibodies that can measure some of these antibodies on very low amounts. So these are low amounts, but they really stick to those acetylcholine receptors. So they're called high affinity. So of that 10 to 15% of individuals who don't have detectable antibodies, a few percent, maybe 2 to 3%, actually do have antibodies. We just don't have a really good way of measuring them at the current time. These patients are often diagnosed with electrodiagnostic testing. And in the bottom right-hand corner of the screen, I've shown what's called a repetitive nerve stimulation. In this, we do multiple zaps of electricity over the same nerve in very short sequence. And in people who have myasthenia gravis, we'll see a good response initially, and then it'll drop, 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 and then kind of level off, and then sometimes even increase a little bit at the end. So that's what this is showing. Drops, 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 and then kind of levels off. That is diagnostic of a neuromuscular junction abnormality. We don't always see that. Sometimes people can have myasthenia gravis and have normal nerve conduction studies with repetitive nerve stimulation. In that case, we often go on and do a single fiber EMG. Some of you may have had a single fiber EMG. That's often a very time-consuming, challenging test. You have to maintain a low level of activation of the muscle, and the needle is often in the muscle for 15, 30 minutes, sometimes even longer than that, as the operator really tries to get just 2 fiber pairs that fire very close together. But that is thought to be pretty sensitive to pick up neuromuscular junction abnormalities in somebody who has symptoms of myasthenia gravis. And then finally, we also see something called striational antibodies. And these are mainly to RYR1 or titin, which are 2 other internal proteins that are found in muscle. So these are not on the cell surface of muscle, but they're internal, and they help with calcium influx, or might help with how the muscle actually contracts. If these antibodies are present, they don't always indicate that somebody has myasthenia gravis, because they're not thought to be directly pathogenic. But if they are present, especially in a younger individual, it's highly suggestive that somebody may have a thymoma. So in the next 15 to 20 minutes, I'm just going to touch briefly on all of the available current therapies and maybe a little bit on where we're headed in the future. We'll talk first about the thymus gland. We'll mention some of the current immunosuppressive therapies, also mestinon or pyridostigmine, the anticholinesterase therapy. And then we'll talk about some of the other therapies that act directly on B cells or help to facilitate removal of the antibodies that our B cells produce. So thymectomy. This is very likely to be most beneficial in young people with acetylcholine receptor myasthenia gravis. There was a study done from 2006 to 2016. It only included individuals with known acetylcholine receptor positive myasthenia gravis, and they set the age cutoff around 60, although they ended up expanding that out to the age of 65. These were people without known thymomas. So if you had a thymoma, you were out of the trial and you probably had surgery to remove the thymoma. But what this trial showed was that in individuals who had the thymectomy, they required a lower dose of prednisone overall to achieve lower levels of disease, what we call minimal manifestations. So they could have ocular symptoms, but otherwise their speech, their swallowing, their strength, their breathing were all thought to be normal or near normal. There were also benefits seen in the quantitative myasthenia gravis scale. There were lower risks of exacerbation and lower risks of hospitalization. So from that trial, we really understood that thymectomy can be beneficial in acetylcholine receptor. But this trial excluded MuSK-positive myasthenia gravis as well as seronegative. And LRP4 really wasn't tested well at that time, so it very likely excluded LRP4 patients as well. And that was mainly because by anecdotal reports, people who had MuSK-positive myasthenia gravis, really, some people actually worsen after thymectomy. And so this really hasn't been studied vigorously in MuSK-positive myasthenia. And because seronegative was excluded, also really wasn't studied vigorously there. Pyridostigmine, almost everybody who has or who has myasthenia gravis is given pyridostigmine initially for symptomatic relief. It works best when somebody has very mild symptoms of myasthenia gravis. When symptoms are more moderate or severe, it doesn't work as well, because what this medication does is it allows that acetylcholine, that enzyme that helps to transmit the electrical signal, sit out there for longer. But if there aren't receptors that are available to receive that signal, it doesn't really matter how long the acetylcholine sits out there. If there's no receptor, you can't get that signal across. This does tend to work better in acetylcholine receptor positive and some seronegative patients than MuSK. A lot of patients with MuSK-positive myasthenia gravis will develop a lot of uncomfortable muscle twitching or muscle fasciculations, and just in general seem to have not as good of a robust response to the therapy. Prednisone, this medication has been around for decades. The general thought is that we start out low, maybe 5 or 10 milligrams a day, and increase it slowly, because we have seen that abrupt high doses of steroids can worsen myasthenia gravis. Usually can be as early as a couple of days, more typically between 5 to 8 days after starting, potentially as late as several weeks. But that time period of within the first week, we often see worsening if steroids are started at high dose right away. If somebody is receiving IVIG or plasma exchange, you can start higher dose steroids. Those therapies often help to protect from that relapse. We often see the benefits start at about 2 to 3 weeks, with a peak effect usually within several months. And benefits can be seen in all forms of myasthenia gravis. Unfortunately, as many of you know who have taken steroids, there's a really long list of very potentially bothersome side effects. Irritability, insomnia, weight gain, swelling, can thin out the skin with long-term use, can thin out the bones, so osteoporosis is common over time, can upset the stomach, lead to GI ulcers. A lot of side effects that make this a less than ideal long-term therapy for many patients. Many of you have also seen or heard or taken one of these medications. We have probably 5 or 6 immunosuppressive therapies that are available in a pill form. Azathioprine probably has the best evidence out there, helps to control symptoms, but really requires somebody to be on it for probably 12 to 15 months before we really see an effect. Cyclosporine tends to work much more quickly, usually within 3 to 6 months, but it has a higher risk of side effects, tremor, potentially kidney injury, potentially push somebody into a diabetic state. Mycophenolate, methotrexate, and tacrolimus, all of those are out there as well. Maybe not as good evidence, but still used in some individuals with myasthenia gravis. All of these medications act on the T cells or B cells to slow down their replication and hopefully reduce antibody production. So none of these are really directed at a specific type of myasthenia gravis. Can probably work for any type, but nothing specifically directed the way that we might like our treatments to be directed. And also all of these, even though I say cyclosporine has the most side effects, many of these carry some risk along with them, require frequent blood monitoring as well. Plasma exchange and IVIG. I consider these pretty equivalent, but some people do respond better to one than the other. These are widely used when somebody becomes very ill with myasthenia gravis and is hospitalized. It's also used as maintenance therapy for many people. With that being said, plasma exchange can be challenging to coordinate if you live far away from a facility that does plasma exchange. Not every facility does this. And IVIG has risks of skin rash and headaches along with it. In general, I think plasma exchange probably works a little bit faster when we have somebody who's critically ill with myasthenia gravis. But because many patients need a port or a line, there's some potential infection risks or procedural risks that go along with it. To compare these two, IVIG is given as an infusion. It can be done through just a usual peripheral IV in the arm. Antibodies are given. These antibodies act on the immune system to tell it to quiet down and maybe even help to filter, remove antibodies out. The infusions themselves can be somewhat lengthy, often 4 to 6 hours. When somebody's really sick, we'll often give a loading dose. So that's usually given over several days, maybe even out to 5 days. I mentioned headache and rash are pretty common side effects. Reaction to infusions can also be seen. Plasma exchange has a different set of side effects, risk of infection, potentially heart problems if there's a heart arrhythmia. The sessions are shorter. You filter out the blood and return the serum with some protein, but filter out those antibodies. And this is often done as one exchange every other day for 5 total sessions. So when somebody's really sick, it usually takes 10 days total to do all of those sessions. For maintenance therapy, it can be one exchange every week or one exchange every 2 weeks or potentially one exchange every 3 or 4 weeks. Usually lasts for about 3 weeks, but that varies by individual. Rituximab is a B cell depleting therapy. So rituximab is a monoclonal antibody. It binds to B cells and they are removed from the system. After rituximab is given, our B cells drop to nearly undetectable levels very quickly, usually within days to weeks of that therapy, and they'll remain very low for about 6 to 9 months before they start to build back up. Rituximab works very well in many people with MuSK myasthenia. For me, it's often the first line, or if not first line, maybe second line therapy for MuSK positive myasthenia. There was a study looking at acetylcholine receptor, and the evidence there was a lot less benefit seen. Some benefit, but not like with MuSK, where we often get people feeling pretty good for 6 to 9 months before they need another treatment. And now, just to mention a few of our new and our emerging therapies. So some of these are already out there. Our complement inhibitors, and I'll probably not get the names all right, but eculizumab, ravulizumab, and zilucoplan. All of these are out there now. This last one was just FDA approved in late 2023. We also have several products that help to remove antibodies. That's efgartigimod and rozanoliximab. So those are available. We mentioned rituximab already. These other ones that regulate T cells, these are not yet available. There's some ongoing studies looking at whether they can be effective at improving the symptoms of myasthenia gravis. So our complement inhibitors, we mentioned earlier that acetylcholine receptor antibodies activate complement. That's part of the immune system that really leads to damage to the muscle membrane and damage and destruction of the acetylcholine receptors. Some of that is reversible, but over time, some of it may not be fully reversible. So these current available treatments block that activation of complement and thereby hopefully allow that muscle membrane to heal or at least stop that damage that's occurring to it. These all have some differences. Eculizumab is an IV infusion. It's given every 2 weeks. Some patients, many patients are on other immunotherapies and may still need that because this doesn't really suppress the whole immune system. You're still producing those antibodies and they can still functionally block or lead to internalization of the receptors. So it really just blocks part of the process. When this medication was approved originally, it was approved actually for a couple of hematologic conditions first. And there were some initial concerns about meningitis infections. And so we need to vaccinate for meningococcal infections before we start these medications, unfortunately. And then Xylocoplan is a subcutaneous injection. There's maybe some meningitis concerns, but I didn't see quite as much, and that was just approved. I don't even know if that's out and available yet, but hopefully soon. And then ravulizumab infusions. These are ideally supposed to maybe replace eculizumab, and it's certainly more convenient for patients because now you're only getting an infusion every 8 weeks instead of every 2 weeks. And so you fewer trips to the infusion center, maybe more ability to travel, and you don't have to worry about being around at the time of each infusion. So I've prescribed eculizumab, and I have prescribed ravulizumab in the past few years. Ravulizumab just is newer. And then our treatments that are called neonatal FC receptor blockers. So these FC receptors are part of our immune system that helps to keep our immunoglobulins in circulation for longer. By blocking these, the antibodies end up getting taken out of the system sooner, more frequently, and that helps to hopefully reduce the total number of antibodies that are circulating in the blood. And it doesn't appear that, at least at the current time, that our immune system picks up additional production. So there's a couple of these that are available. Efgartigimod is given as an IV infusion. It's given weekly for 4 weeks with a 28-day break, potentially longer if somebody's doing well. So the clinical trial looked at that infusion length with at least a 28-day break. Efgartigimod is only approved for acetylcholine receptor positive myasthenia gravis. The newer one, rozanolixizumab, which I mispronounced, rozanolixizumab, sub-Q injections given weekly for 6 weeks, and then a period off, and then redosing. This one I have not prescribed yet, but I did have a patient that had asked about it just recently. So maybe in the near future we'll try it. So I don't have too much experience there. Looking at these treatments, there are a lot of new treatments. Just in the last 4 or 5 years, we have 5 brand new treatments that are very directed treatments for certain subtypes of myasthenia gravis. With that being said, it's probably not the end of the story. The complement inhibitors really only attack one part of the immune system, and part of the immune system is still active, producing antibodies. And our neonatal FC receptor blockers, that's really affecting all forms of antibodies as opposed to a very specific targeted attack just on myasthenia antibodies. So there are some potential infection risks, although the trials didn't show a super high risk of infection. But we could probably do a little bit better with even more targeted therapies, if possible, that really just isolate and pick out just those MuSK or just those acetylcholine receptor antibodies. So in summary, about 85% to 90% of people with myasthenia gravis have identifiable antibodies. These syndromes, acetylcholine receptor, MuSK, LRP4, and seronegative, all present with very similar symptoms. So you can't tell by looking at somebody what they have. You test out of the bloodstream, and then once you know their type, that can help to direct our therapy. Acetylcholine receptor is far and away the most common form of myasthenia gravis. And we know that thymectomy can be very beneficial in acetylcholine receptor positive myasthenia, especially younger patients. And complement inhibitors appear to have a role there as well. Thymectomy is pretty limited efficacy as far as we know in MuSK especially, and having seen some patients who worsen after thymectomy with MuSK, I'm really reluctant to head down that pathway unless everything else has failed. Pyridostigmine, mestinon, often worsens MuSK-positive myasthenia, but helps many other subtypes of myasthenia, especially when it's mild, but not when severe. And rituximab and plasma exchange really work well, especially for MuSK myasthenia. Future directions, hopefully we'll have some very specific therapies that are aimed right at the MuSK antibody or right at that acetylcholine receptor antibody. Hopefully that will help to avoid some of the side effects and risks of infection that often go along with suppressing the immune system. And so there are ongoing trials looking at some more specific therapies, and hopefully those will pan out and be as beneficial, if not more beneficial than what we already have. That is all that I've prepared. I can take some questions now. I don't know if it would be better if I stop sharing the screen just so that we can see everybody.
We do have one question. We actually have quite a few questions since I looked the last time. Why are some people testing positive for LRP4 in Augusta study, but negative in Athena?
So that's a good question. And I don't have a certain answer on that because I don't know how they're testing for it in Augusta or how they're testing for it in Athena. But the typical lab tests are something called a RIFA, and those tests don't pick up everybody. There are some cellular-based tests that appear to pick up antibodies that are present in a very low amount in some people. So those people that have very low amounts might be escaping detection based on how they're running their antibody test.
You know, and one of the things that you said that I thought was interesting is somebody who has a high antibody level and somebody has a low antibody level could have reciprocal versions of MG, or the amount of symptoms that they have, so that antibody level doesn't really correspond to the gravity of their MG. It just is testing their antibody level, and it's still left to figure out all that other stuff. I think in a follow-up, this same person asks, is Athena diagnosis only placed to be tested for unique antibodies?
Yeah, so I often have a hard time getting LRP4 testing done. Athena tends to charge a lot of money for their antibody tests and for all their tests. And a lot of times insurance doesn't like to cover it. I did see recently that Quest Diagnostic appears to be running tests for LRP4, although I don't think I've personally sent any tests recently to Quest Diagnostic. Acetylcholine receptors are pretty, that's pretty ubiquitous. Most people can get that through any local lab. Mayo Medicine, U of M sometimes, Michigan Medicine sometimes sends tests out to Mayo. So I know Mayo runs testing for MuSK as well as acetylcholine receptor antibodies. I don't know that they always test for LRP4. So the main one that I'm aware of would be Quest Diagnostics appears to have a test for LRP4 now. Unfortunately, I've found a lot of the research-based testing is difficult to access. Kind of probably have to reach out to a specific lab if you know which lab is able to run that.
Yeah, one of the questions I had is, again, about the assay-based testing and whether that's commercially available yet. I know it's available from the lab standpoint of a research-based, and Swedish in Colorado is one of the areas that I know that some people have gotten it. But one of the questions I had is whether that is something that Michigan Medicine is able to do, or is that currently not available?
I have not yet seen that as widely available as I'd like it to be. So no, I don't think U of M is running that type of testing, and I don't even think Mayo is.
Okay, next question is, while treatments are allowing for targeting to specific antibody presence, it would seem that those of us who are seronegative are being left out. Are there any treatments being developed for the seronegative crew, recognizing that by definition this makes it difficult to pinpoint, but are there any studies specific to the seronegative patients?
So there are some studies. In fact, even some of the studies that have been completed the efgartigimod study included patients who had acetylcholine receptor MuSK and seronegative. The problem came when they went to submit their information. Since acetylcholine receptor positive is so common, most of their patients were acetylcholine receptor, and they were asked to gather additional data on MuSK and seronegative patients. So part of the challenge is in a already rare disease with a subtype that is only a 1 to 5% of individuals, it's hard to get a large enough scale trial together. You really would require a multi-center trial, which does happen, but even then it's often hard to recruit enough patients to power the study to find a benefit. So I agree. With MuSK, LRP4, and seronegative, it is really hard to get a good uniform study. And for seronegative, especially since we don't know what antibody is driving the pathology, it makes it doubly hard to develop a very targeted therapy. At least for acetylcholine receptor or MuSK, we understand what those antibodies are, and a lab could potentially design a treatment that's very specific to those antibodies. But for seronegative, it's definitely tough, and I wouldn't give up hope. I think people will develop treatments, but it is a more challenging area for sure to study.
Next question is, I appreciate your presentation. I have LRP4 antibodies, but was later told by a neurologist that it was all in my head because Mestinon and prednisone didn't help. And I think that that's the struggle for a lot of people who go through the antibody testing, not just the first phase, but for other phases, and it's and then what? So now I know what antibodies, but again, it's the pathology in order to be able to have a targeted therapy. What is kind of your feeling on that? And Julie is the person who asked that question.
Yeah, thank you, Julie, for asking that question. That is a really it's a really challenging scenario. It sounds like you have definite myasthenia gravis. I guess it's hard to know based on your symptoms, but if you have those antibodies, we do think that LRP4 antibodies, as well as MuSK and acetylcholine receptor, those are pathogenic. They cause the disease, and in the right set of symptoms, they can certainly be a characteristic. We think that about 1 in 10 people with myasthenia gravis are refractory to standard treatments, and Mestinon and prednisone are really just the start of treatment. Just because somebody doesn't respond to those doesn't mean that they won't respond to other therapies. We don't have a good way of predicting who will respond to which therapy. We know that certain subtypes will respond better. Unfortunately, LRP4 is one that we don't really know for sure what therapies work best. And so it does become a little bit of a frustrating trial and error process of figuring out what medications help and what medications don't help.
Thank you, Dr. Gallagher. That was a good explanation. I think that that's the frustrating part, that it is people who, definitely know that their symptomology is there, but it's the what's next. This is a good question. Are there tests we can have to find out what kind of antibodies we have? And how would somebody who is currently has MG, who has not had their antibodies determined, is there a reason for them to do that?
Yeah, I would say yes. If you were diagnosed with myasthenia gravis based on symptoms, and sometimes people just get that electrodiagnostic test that we discussed. If you were diagnosed with myasthenia gravis based on that, I do think there is a benefit of knowing which antibody you have, because if you don't respond to the first treatment or two, there are other treatments, newer treatments that are coming out that we know target very specific areas of the immune system. We know that there are certain treatments that work better for one type of myasthenia gravis than another. So I do think it's worthwhile figuring out. One challenge can be, and I don't know if I saw this in the chat as well, but one challenge can be when somebody is on plasma exchange or is on IVIG, those treatments and rituximab, those treatments remove antibodies from the immune system. So sometimes when somebody's on treatment, their antibodies may not be easily measurable. We'd call that a false negative, somebody that has antibodies, but they test normal or negative for them. And that sometimes can happen when somebody's on an immune therapy already. So it's best to test before you start therapy, especially IVIG or plasma exchange.
This person asked specific information about their own symptoms, so I'm going to generalize it so that it is not specific to that person. They have double vision. They were given prednisone and mestinon. It has worked. They say they are no longer on prednisone, but once double vision flares up, which is about every 5 to 6 months, they have to take prednisone again. Should he or she be tested for antibody to see, and if so, how often? I think how often would they be tested, I guess, is the question.
So ideally, you would be tested at the time that you're diagnosed. Most people that have antibodies, those antibodies are present at the time of diagnosis. I think there are some people that test initially negative, and then when retested 3 or 6 months into the course of illness, can sometimes test positive at that point. But I would say if you've been tested 2 or more times and you continue to test negative, unless we get a new cellular-based assay, it's not worth testing every time that symptoms flare. And after you've been tested a couple of times, probably not likely that you're going to suddenly convert to a type of myasthenia gravis that was already tested.
This is a common question, and it's a reminder that the MG-ADL and the double vision, if it's the one thing that bothers you the most because you have to drive or it's something that you're doing often, it becomes the symptom that really you need to be better. But this person says IVIG helps them with swallowing muscles and droopy eyelid, but doesn't reduce double vision symptoms. Does it mean that I have 2 different kinds of MG antibodies?
No, not necessarily. Of the symptoms that we treat, ocular symptoms, double vision, are often the most challenging to get to go away. So it's possible that symptom just isn't very responsive to treatment. And sometimes we try all the treatments that we have out there, and none of them work, as well as we would like. You could still be tested for all of the known types of antibodies just to see if one of those other ones turns up. On IVIG, though, we'd have to interpret that a little bit cautiously. Just if you test negative, you don't know for sure, did IVIG affect that measurement?
IVIG or Plex.
Yeah.
So one of the things is I saw that ocular, only 50% of the people with ocular test positive for or certain IG antibodies. Is that only IG 1 and 3, or is it, do we know that much about ocular antibodies?
Well, about 50% are acetylcholine receptor positive for ocular. Some people do convert over time in that ocular group, and some people who have ocular symptoms end up generalizing and having additional symptoms. It is possible if somebody maybe starts with ocular symptoms and maybe there's some damage that occurs to those ocular muscles before treatment started and before it's fully reversed. That may be one reason why, and that could be complement driven for sure. I'm not sure if that answers the question.
The one question I had is because complement is what damages the muscle. So essentially, if there's complement and antibodies aren't testable, you still have complement. Do we have a test specifically for complement?
Yes, we do have a test for complement. You can measure complement levels, but I don't think that can tell you the level of disease activity in myasthenia gravis. That's not not a standard test that would run for myasthenia, and I haven't seen anything correlating specific complement levels. So I don't think that would be helpful.
Okay. From your experience, can MG cause CPK levels to be 2 to 3 times above normal?
Um, It's it is possible, but we usually think that although myasthenia gravis does damage that muscle membrane, usually we don't see CPK levels that leak out as part of the disease process. Most people that um, have myasthenia gravis have normal CK levels. It's possible that there's a separate process ongoing. About 5% of people just normally have CPK levels that are a little bit high. Usually when somebody doesn't have a muscle problem, but their CPK is high, it's usually in that range of 2 to 3 times normal. So maybe 400 to 600. Normally CPK is usually under 200. So I'd say it's possible it's MG related. It's possible that could just be your normal value. Sometimes we don't know though until it's checked.
So there was a comment from Rhonda that zilucoplan is available from UCB, and that was just knowledge for that, and it is kind of in the market. So Ashley is commenting on something that Julie said. She found this talk informative. Dr. Gallagher, she mentions that she doesn't feel you practice what you preach. She has been under your care. That's specific to a patient, and so that's probably not
Yeah.
something we're going to go on with. But I mean, one of the things that is difficult is, and especially for your center, and we have the same thing that happened at the center I work with, is where you have clinicians who are no longer there. In the case of a clinician who dies unexpectedly, sometimes you have this movement of patients from one person to another, and continuity of care is one of the things that you hope to provide for all patients. And it isn't important, but it's also almost a physics issue in that you have people that you probably have a full caseload already, and now somebody has to accept those other patients who still need to be seen as part of that caseload. And so I'm sure that has been going on a lot in your practice, and at least kind of sifting people in the care of patients who had been with a previous provider. In our center, unless you have agreement with that provider, going to another provider is very, very difficult. How does Michigan Medicine handle that if somebody wants to go to another provider?
Yeah, so that is, definitely a challenge. We often struggle to get everybody that wants to be seen at Michigan Medicine seen in a timely fashion. So we get, not only, many new referrals every week, but all of our current patients that need follow-up. And as we mentioned at the beginning of this talk, we had one of our providers who unexpectedly passed away a year ago. And, we had to absorb and find a way to make sure that all of his patients were seen. And
Yeah.
so that made it, very difficult because every provider kind of already had a full or relatively full schedule. And then you've got hundreds of patients who also definitely need to be seen still. And so we tried to do the best. All of us at Michigan Medicine have many patients with myasthenia gravis, and everybody in our neuromuscular division takes care of myasthenia gravis. And so we weren't really able to, I don't know if some people had requested specific providers, but it was very hard for us to, align patients with just the provider that they wanted to see, because their next appointment might have been 9 months or 12 months. And if they need to be seen in 2 or 3 months, we just didn't have that availability. We do occasionally have patients who will switch providers, but for the same reason, that's often difficult to accommodate. if our next appointment isn't 6 months or 9 months down the road for a new patient, it's, how do you effectively care for that patient in that time where they're, trying to transition providers? So I don't have a great answer for that. I think it is something that we struggle with because we want to see everybody that we can, and it's not always possible to see everybody as quickly as what we would like to see.
I think that that's the first of all, all of us have been through just a 3 years of turmoil, and neurology was certainly involved in that turmoil of um, people who we couldn't see in person, and we were switching people to ways where we could see them. And sometimes this MG is definitely a disease where you want to do muscle testing and strength testing in person, and that's not something we can replicate on a Zoom call, at least at this point. But hopefully that's a one-time thing, and we've done the best we can during that part, and we've moved on. Are there, and you of course have fellows that are, graduating, on an ongoing basis, because you have quite a fellowship program there. In fact, a lot of clinicians who are in other areas, Dustin Nowacek, I know, has spoken for us before, and he was a fellow, and other ones. Are there, is there going to be an MG only clinic like there was, or is it going to be really just, again, sifting people out into people who have space for them?
I don't, at least right now, I don't foresee having an MG only clinic. The one challenge that I see there is if we were to restrict to like a single day for that MG clinic, that might not fit a lot of people's schedules. And we might only have, say, 1 or 2 providers that become specialists in MG, which is great. But if one of those providers, leaves or, retires, all of a sudden you have a huge gap, and then follow-up is even more troublesome. So I don't, at least in the short term, I don't foresee a specific MG clinic at U of M. We do have trainees that came through U of M that are at various places in Michigan. There are several of our trainees that are out on the west side of the state at Corewell Health at the old Spectrum. Dr. Sachdev is up at Michigan State, and Dr. Nowacek is up at Memorial in Owasso. So we do have some trainees at other places as well. I don't think Dustin is actually a very good friend of mine. He and I were in fellowship together. I don't think that he has a specific myasthenia clinic either. I think he just kind of sees everybody on whichever day they can come in.
Yeah. So Sam Barber, who had been a patient of yours and now has moved to another area, gives you a very good compliment. Lisa, did I miss any other questions that I didn't get to? Oh, I did. There's one other one from Sam. Is there a metric to determine whether an MG patient is in remission as opposed to just under maintenance or asymptomatic?
So that's another really good question.
$100,000 question.
Yeah, so unfortunately, we can't always rely on the antibodies. I have a couple of patients who continue to test positive for acetylcholine receptor antibodies who did well for a period of time, years. Couple of them had eventual relapses, so they still have the disease. It's just in remission, and so no, I don't know of a good way. I think anybody who has myasthenia that has known antibodies, or even somebody who's in that seronegative group, even if they go into remission, probably still good to have a neurologist that you follow with annually as a way of getting back in touch in case symptoms do come back. I rely a little bit on that MG-ADL scale. That gives me an idea from a patient perspective how they're doing, as well as any objective findings that I can see in clinic in an exam. So it's a challenge for sure.
Well, you've been very informative, and I really appreciate you being able to kind of dive into this topic. I think it's going to become more important as, specific drugs are released and as we kind of evolve, and we certainly have been at the forefront of MG therapies that are, available to people with MG that, it felt like we were in kind of a perched area for a while that we just didn't, there were no new therapies. And I think that we're in the opposite of that now. And it's kind of really good to see people. One of the things that I have seen, at least in our clinic, Dr. Melanie Taylor is our director of, and many more people continuing to work and working, especially somebody who is younger who may have presented at an emergency situation, and that's when it was discovered they had MG and still able to go back to work after a period where they were trying to get their disease under control. And I think that's what everybody wants. They don't necessarily want to go back to work if they're 80 years old or don't want to work themselves. But if you're young or you are in a position where you have to provide for your family, I think that's what everybody wants. They want to have their regular life that they had providing for their family. And I think that is becoming more and more possible with some of the newer therapies, because they also are given in a way that allows them to do it in without an infusion over 4 days or 10 days, like they'd have to do with Plex. So
Yeah.
thank you very much for joining us. I appreciate it. We're going to end this webinar now. Thanks for joining us, everyone. I appreciate it, and have a good evening.
Thank you.